Hello everyone. Welcome back to this short tutorial from Pathology Made Simple at ilovepathology.com. This is the part 2 of Adrenal Gland Pathology series. And in this part, I'm sure looking at the illustration, you know now that I'll be talking about Cushing's syndrome. So in the next 10 to 15 minutes, let us see the differences between Cushing's syndrome and Cushing's disease. We will look into some historical aspects. We will list out all the possible causes of Cushing's syndrome, a bit about morphology, in detail about clinical features, lab diagnosis, treatment, and prognosis of Cushing's syndrome. So, if you recollect what we had discussed in the part 1 of adrenal gland pathology series, we had talked about the anatomy and histology of adrenal gland, the functions of adrenal gland, and various diseases associated with adrenal gland, right? So, we talked about hyperfunction, hypofunction, and neoplasms involving both cortex and medulla. So, in this session, we will be talking about a very important adrenal gland hyperfunction state that is called Cushing's syndrome, which is also hypercortisolism. So, hyperfunction basically, we will be understanding the concept of excess of glucocorticoids, which is also referred to as hypercortisolism, which is commonly called as Cushing's syndrome. And now you also have Cushing's disease. So you need to understand what exactly are the differences between Cushing's syndrome and Cushing's disease. Dr. Harvey Cushing, he was an eminent neurosurgeon in the United States. Way back in 1910, he described, a particular case series. In all these three articles are from Dr. Cushing. Specifically, a woman named Minnie G. Dr. Cushing described her clinical features. He described it as, a syndrome of painful obesity, hypertrichosis, and amenorrhea with overdevelopment of secondary sexual characteristics. And that was accompanying a low grade of hydrocephalus and increased cerebral tension. Okay, he thought it could be pituitary, it could be adrenal, pineal, or even ovarian cause. So a few years later, because Dr. Cushing described this particular case, it is called as Cushing's disease. So basically, Cushing's disease is a disease having all these manifestations due to a pituitary cause, right? So Cushing's syndrome versus Cushing's disease, meaning Cushing's syndrome is a general terminology where it denotes hypercortisolism. It can be due to any cause, right? Whereas Cushing's disease is also hypercortisolism, but this is because of excessive secretion of ACTH, adrenocorticotropic hormone, by pituitary corticotrope tumors. Okay, and that leads to hypercortisolism, leading on to Cushing's syndrome. So, Cushing's syndrome is the name which has to be used only when you see hypercortisolism only due to pituitary cause. Now let's move on to understand the causes of Cushing's syndrome. The causes can broadly be categorized into endogenous causes and exogenous causes. The endogenous causes can be due to pituitary or due to ectopic hormone secretion. Ultimately, both of these leads to increased secretion of adrenocorticotropic hormone. One is directly from the pituitary, which is approximately around 60 to 70% of cases, whereas in around 5 to 10% of cases, it could be because of ectopic hormone production. So, what are these pituitary causes? The pituitary causes can be either due to hyperplasia of the pituitary gland, it could be due to microadenoma of pituitary gland or macroadenomas of pituitary gland. All these three things can result in increased secretion of adrenocorticotropic hormones, right? Now, what are the causes of ectopic hormone production? The most common cause is the small cell carcinoma lung. Okay, it's basically a paraneoplastic syndrome where these tumors they secrete more and more ACTH like substances. So the most common cause of ectopic ACTH secretion is small cell carcinoma lung, followed by carcinoid tumor, which is a very small yellowish tumor which is seen in the bronchus. The third one is medullary thyroid carcinoma, basically a neuroendocrine carcinoma. And fourth one is pancreatic islet cell tumors. You also have, neuroblastomas, pheochromocytomas can also result in increased secretion of ACTH as well. But then these are the four most common causes of ectopic secretion of ACTH. Okay. Now, what will happen if there is increased secretion of adrenocorticotropic hormone? Obviously, that stimulates the adrenal gland, resulting in hyperplasia of the adrenal gland, right? So, once there is hyperplasia of the adrenal gland, what happens? That leads to adrenal hyperfunction. Okay, that adrenal hyperfunction leading on to hypercortisolism. Okay, adrenal hyperfunction can be, increase in mineralocorticoids, increase in glucocorticoids, or even increase in sex steroids. But then in today's session, we are looking at hypercortisolism alone, right? Hypercortisolism, adrenal hyperfunction, and this is called as Cushing's syndrome. So basically, Cushing syndrome is increased secretion of glucocorticoids due to any of these causes. So if it is pituitary only cause, then it is referred to as Cushing's disease as we described earlier, right? Adrenal hyperplasia or adrenal hyperfunction need not always be due to increased secretion of ACTH. Okay, it can also be ACTH independent. It could be adrenal gland pathology itself, like adrenal gland adenoma, which constitutes around 10 to 20% of endogenous causes of Cushing syndrome. It could be because of adrenal carcinoma, constituting around 5 to 7% of endogenous causes of Cushing syndrome. Okay. Now, adrenal hyperplasia can also be ACTH independent. Okay. So, what we saw earlier was it is increased secretion of ACTH which stimulates adrenal gland leading on to adrenal hyperplasia, right? Adrenal hyperplasia can also be ACTH independent. It can be either familial or sporadic, and that's due to some mutations in these cells. Okay, that's very, very rare. But then you should know that adrenal hyperplasia can also be ACTH independent. So these are the ACTH dependent and ACTH independent causes of adrenal hyperfunction. That's about endogenous causes of Cushing syndrome. Now, moving on to exogenous causes, which means there is administration of exogenous glucocorticoids. And why do you do that? That's basically in the process of treatment of chronic inflammatory disorders or chronic immunological disorders. Okay, you keep on giving glucocorticoids for a long period of time, and that can lead to increase in glucocorticoids, leading on to Cushing's syndrome. So these are the various causes of Cushing's syndrome, right? Endogenous, exogenous could be ACTH dependent, ACTH independent, pituitary cause, non-pituitary causes, and adrenal gland causes. Right? So that's about the causes of Cushing's syndrome. The morphological features of Cushing's syndrome. See, irrespective of the cause, the lesions are found both in pituitary as well as adrenal gland. Right? So in the pituitary, what really happens because of high levels of glucocorticoids, whether it is exogenous cause or whether it is endogenous cause, whether it is ACTH dependent or independent, doesn't make a difference. Excess amount of glucocorticoids in the serum leads to accumulation of intermediate keratin filaments in the cytoplasm of the cells of the anterior pituitary, right? And once there is accumulation of these filaments, the cells become homogeneous and paler, and this is referred to as Crookes hyaline change, a very characteristic feature which you find in Cushing's syndrome. Normally, the cells of anterior pituitary are granular and basophilic, and now becomes more homogeneous and paler. Okay, and that is called as Crookes hyaline change. Now, what do you find in adrenal gland? So, if the disease is due to exogenous steroids, what happens? Then there is suppression of endogenous ACTH because you are supplementing with steroids. There is no ACTH from the pituitary, and there is no stimulation of adrenal gland. So that leads to bilateral cortical atrophy of the adrenal gland. How do you identify? You identify based on decreased zona fasciculata and zona reticularis. Remember, zona glomerulosa is not dependent on ACTH. Okay, that's why in these cases, zona fasciculata and zona reticularis are decreased in volume. Now, if the Cushing syndrome is because of endogenous hypercortisolism, then adrenal gland can show various pathologies. And these pathologies include diffuse hyperplasia of the adrenal gland. The hyperplasia can be in the form of tiny nodules. Nodules, it can be micronodules or macronodules. It can be in the form of adenoma or it can be in the form of carcinoma. Okay. Now, diffuse hyperplasia, what do you see? You see increased volume of zona reticularis and fasciculata throughout the adrenal cortex. Whereas in the case of hyperplasia in the form of nodules, these nodules can be of varying sizes. If the size of the nodule is less than 3 mm or equal to 3 mm, it is called micronodular hyperplasia. If it is more than that, it is macronodular. Usually, the macronodular will be around 10 to 30 mm in size. Adenomas are mainly yellowish tumors which is surrounded by a very thin or a well-developed capsule. By definition, benign tumor has a capsule, right? So adenoma has a capsule which is an yellow tumor and the tumor cells just look like that of a normal zona fasciculata cells. Whereas carcinoma is the larger one. It just tells you all other features of malignancy. They are large, unencapsulated, invasive tumors. And then in cytological, in histopathological examination, you find all features of anaplasia. Okay, the cells are very pleomorphic, bizarre. You have lots of mitosis and so on and so forth. So that's about the morphology of adrenal gland in Cushing's syndrome. Now let's understand the clinical features. How do these patients manifest? Okay, so the clinical features, I'll just try to explain clinical features with this illustration. The most important clinical feature would be weight gain. Now, why is there weight gain? Because the glucocorticoids, they are the ones which promote lipogenesis and they inhibit lipolysis. So there is more and more accumulation of fat. And this accumulation of fat is more so in the trunk, in the back, and the face, right? And because these are the areas where they have a lot of adipokine receptors. So that's why there is more and more accumulation of fat in these areas. So leading on to truncal obesity, moon-like faces, accumulation of fat in the posterior neck and back. And that's what we refer to as buffalo hump. Okay, that's the most important clinical features. That's weight gain. Second one is the decreased muscle mass. And why is there decreased muscle mass? And that's because the hypercortisolism, it causes atrophy of type 2 myofibers. And that's why there is, wasting of muscles. The extremities are very thin. And also there is weakness of proximal muscles, proximal limb weakness. Thin extremities are very characteristic feature of Cushing syndrome. And that's why a colloquial term, lemon on matchstick appearance. Okay, the pot belly, the moon faces depicting the lemon and the thin extremities depicting the matchstick. Okay, lemon on matchstick appearance. You should remember we are dealing with the case of Cushing's syndrome. The third one is metabolic features, where the causes, the reasons for metabolic manifestations are because of these corticosteroids, glucocorticoids. You know that they induce gluconeogenesis, they increase the uptake of glucose, and that's the reason why these patients manifest with hyperglycemia, polyuria, and polydipsia. So that is secondary diabetes. So Cushing syndrome is another cause for secondary diabetes. Now, hypertension in cases of Cushing syndrome, and that's because these glucocorticoids also have some amount of mineralocorticoid activity. That's why these patients manifest with increased blood pressure. Okay, sometimes they have mood disturbances in the form of mood swings, depression. In very rare cases, this patient can manifest with severe psychosis as well. Another prominent feature which you need to understand is the skin changes, and the skin changes is because of the catabolic effect of glucocorticoids, where there is loss of collagen in the dermis. Okay, and that's why the skin is thin, the skin is fragile, and they can be easily bruised. Because the striae are very common, particularly when there is increased deposition of fat. It stretches the skin, thereby leading on to the striae. And even if there is a wound, there is delayed wound healing. Okay. What are the musculoskeletal changes? And again, that's because of catabolic effects, where they glucocorticoids increase in. They causes more resorption of bones, leading on to osteoporosis. Vertebral bones are more commonly involved, and that's why these patients manifest with backache. And then there are also susceptible to fractures because of brittle bones, right? So these are the musculoskeletal manifestation. Now, as you know that in the immune system, these glucocorticoids suppress the immune response, and that's why these patients are more prone or more susceptible for infections, susceptible to develop infections. The other minor manifestations include gynecomastia in case of males. It can be hirsutism or menstrual disturbances in case of females. So that's all about the clinical features of Cushing's syndrome. How do you diagnose Cushing's syndrome? Of course, the clinical manifestations itself will sort of give you an idea that you might be dealing with the case of glucocorticoid excess, and then you do a 24-hour urine-free cortisol levels, which obviously will be increased. You need to find out the cause for this, right? And that's why you need to measure serum ACTH levels. Why? That's because we know that the hypercortisolism can be ACTH dependent or ACTH independent. You can ask the drug history as well. If the patient is taking exogenous corticosteroids, you have the cause already known to you, right? If the patient is not on exogenous steroids, then you ask the patient to get serum ACTH levels, and serum ACTH levels can be either elevated or low. Okay. Now, what are the causes of elevated ACTH levels? You know, it could be because of either pituitary cause or because of ectopic hormone secretion. Now, how do you find that it is pituitary or because of ectopic hormone production? There is another test which is done, which is called as dexamethasone suppression test. Now, what is this test? This is a test where the urinary steroid excretion is measured after administration of the glucocorticoid, which is dexamethasone. Okay, you have two types. One, you do a low dose testing and then high dose testing. Initially, there is low dose of glucocorticoid is given, but there is no reduction in the urinary steroid excretion. Okay, but you're not sure now. Still, you're not sure whether it is because of pituitary or whether it is because of ectopic hormone production. Now, then you subject the patient for a high dose dexamethasone administration. Then the pituitary, if it is pituitary, the pituitary responds, and then there is reduction of urinary steroid excretion. Once there is a reduction after high dose dexamethasone administration, then you know that you are dealing with the case of pituitary cause. And if there is no reduction, then obviously it has to be ectopic ACTH secretion. Remember, with elevated ACTH level and there is no reduction even after both low dose and high dose dexamethasone suppression test, then it is almost always because of ectopic adrenocorticotropic hormone secretion. Now, if the ACTH levels are low, obviously you will be dealing with you know that you are dealing in with the case of pure adrenal pathology. And even if you do dexamethasone suppression test in these cases, they fail to suppress cortisol excretion. I mean, there is no reduction both in low dose and high dose dexamethasone suppression test. Right. So that is how you diagnose Cushing's syndrome and also try to determine the cause of Cushing's syndrome. How do you treat Cushing's syndrome? It depends upon the cause of Cushing syndrome. One, if you know that the cause is, because of tumors, pituitary, adrenal, or ectopic ACTH producing tumors, the first choice obviously will be surgery and removal of those tumors. If the patient is on steroid treatment for some chronic infections or inflammatory conditions, obviously you have to stop the steroid because the patient is already manifesting with symptoms of Cushing syndrome. And then you can also administer adrenal enzyme inhibitors. Okay, like for example, aminoglutamide, ketoconazole, and metapyrone. These are the ones which are commonly used. That's about the treatment. And what is the prognosis of Cushing syndrome? It is curable. Once you know the cause, once you treat that, it is curable. But except in cases of ectopic ACTH syndrome and adrenal carcinomas, the patient usually succumbs not because of Cushing syndrome, and that's because of malignancy. Okay, if you have a treatable cause, Cushing syndrome is extremely treatable in the sense, if there is a benign tumor, it can be, the tumor can be removed and then other manifestations can be controlled. If it is a malignant tumor, then, the treatment can be very, very difficult and the patient usually dies of malignancy rather than, because of Cushing's syndrome. So that's all about today's session. We did discuss the differences between Cushing's syndrome and Cushing's disease, and then the causes, the morphology, clinical features, lab diagnosis, and treatment of Cushing's syndrome. Thank you for watching. If you have liked this video, hit the like button. Do comment if you have any queries to ask. I repeatedly ask you to comment because these comments are the ones which motivates me to produce more, to create more and more videos. If you feel this channel is useful, don't forget to share so that others can benefit from this. Thank you.